Hi, good afternoon, everyone, and a very warm welcome. We are glad you have joined us today in our Facebook Live on a very interesting topic, SLE. I'm Shamila Parantaman, and I will be your moderator for today. Before I introduce the speaker for today, just a little reminder, if you have any question during the talk, feel free to type them in the comment box below this live stream. I'll bring the questions up later during the Q&A session and they will be answered by our speaker. And also, don't forget to like and share this video with your friends and family so that they can join us and benefit from this live chat. It's an honor to have with us today an esteemed and experienced speaker, Dr. Shamala K Rajalingam. She's our consultant physician and rheumatologist. She graduated from the University of Liverpool, UK in 2001. And since then, she practiced her housemanship and completed her specialization. Her area of expertise includes rheumatology, dealing with inflammatory disorders of joint, tendons. She has for this she live Facebook, which I which is system it's also known as for her. Let's Dr. Shamala.
Hi, everybody. Thank you very much, Hamila, for the nice introduction, sweet and short. Okay, my name is Dr. Shamala. I'm one of the rheumatologists in Assunta Hospital. I think you're used to hearing me talk about joint pains, so probably this is slightly different. Oh, so let's start. So the topic is called SLE, or in short, it can also be known as lupus. So what is SLE? Basically, it's an autoimmune disease. And what is an autoimmune disease? It just means that your immune system has gone wrong or it's been triggered the wrong way, whereby it starts attacking its own tissues. So just remember, your immune system is supposed to protect you against infections, against inflammations. However, in SLE or in any autoimmune disease, it attacks its own tissues. And this can cause widespread inflammation and eventually tissue damage in the affected organ if left untreated. So in short, like I said, you can also call it as lupus. So a little bit of history. So lupus actually means in Latin wolf, and erythematosus means red rashes actually. So in 1851, Dr. Cabaneza discovered red rashes on a patient's face that looked like a wolf bite. He named the rash discoid lupus erythematosus. In 1885, Sir William Osler recognized that many people with lupus had a disease involving not only the skin, but many other organ systems. He named the disease systemic lupus. So systemic just means it is widespread everywhere. So SLE is a term. It was a term coined in the 1880s. However, if you really like to know a bit more, we can tell you that it has many faces actually, and is also a great imitator. And these terms were aptly coined because clinically any organs can be affected and any clinical presentation is possible. I always tell my patients this: one SLE patient is very different from another. So as much as you can compare your notes about your disease, you may not have the same manifestation as the other friend. SLE is a very odd disease in the sense that it can remit and relapse in its course. And this can happen over a few months, few years. So the course can differ from a patient to patient. So unlike some disease where the diagnosis is made on a single parameter, so we're all used to knowing that high blood pressure just means your blood pressure is above 140/90 in 2 to 3 readings, and that's hypertension. Diabetes just means that your blood sugar is above a certain level which has already been standardized. However, in SLE, there is no one particular test. We diagnose SLE using a set of criteria, and most of it involves clinical symptoms, i.e. what you come and tell us, what we see when we examine you, plus abnormal laboratory tests. So like I said, we cannot diagnose one without the other. It is with a combination of things. So it's what we call criteria. And this shows the heterogeneous nature of SLE. So I've just put up 4 different rashes that you can see here. And it can happen over your palms. It's called a vasculitic rash. It can happen over your thighs, in your legs, in your calf, and this is also called a vasculitic rash. And then, of course, there's the other end where you can see this darkening discoloration over the ears and anterior chest wall. This is what we call a discoid rash. So this is just a rash, but there's more to SLE than just a rash, as we all know today. So the symptoms and your antibodies that you have in your body can be found up to 5 years prior to it being prior to it showing up clinically, actually. And sometimes that causes a major delay in diagnosis. So there are few antibodies involved, and one of the common ones you all probably hear of is something called anti-nuclear antibody. That is the commonest antibody in SLE, and it's present in more than 95% of patients. However, we've got a small percentage who do not have this antibody, and they may have other antibodies such as anti-Rho, anti-Ra, anti-SM, and anti-double-stranded DNA. All these antibody tests do help us make a diagnosis. Basically, it helps us fill up and tell you that you probably have SLE. Let's go through who gets affected in the first place. So I always tell my patients this: you do not have to be of any age to get SLE. It can happen to a very young child and up to the age of 60s, 70s. Women are 9 times more likely than men, sadly. Women of childbearing ages, basically 15 to 44 years, are at their greatest risk. And interestingly, Asians, African Americans, Latinos are much more commonly affected than the Caucasians. And again, first-degree relatives of affected persons have got a higher chance of getting affected. So I'm sure you're going to ask me, is this genetic? No, it is not, but it plays a big role. What causes SLE? Interestingly, a lot of things in rheumatology, up to today, we do not have the answer what causes them. But we do know it's got something to do with your genetics, and there's something in the environment or hormonal that triggers it. So in SLE, we know today that it is very related to genetics, hormone, plus something in the environment. And we know it's related to hormone in the sense that most ladies are affected. 9 out of 10 patients are ladies. So it's got something to do with our estrogen and our progesterone. Hence the diagnosis happening more often during the ages of 15 to 44. So diagnosis can be very challenging. Like I said earlier, there is no single test that can tell you yes or no. Patients can get very frustrated sometimes. Sometimes it can take months or even years to come to a diagnosis. And I always tell my patients is making a diagnosis of SLE is like putting together a puzzle. You may have a positive antibody today, but you are perfectly well. 2-3 months down the road, you might start having a fever, a rash, joint pains, and only then we can put the puzzle together and say, oh, this looks and sounds like SLE. You do have SLE. So again, I need to emphasize this. It is diagnosed according to symptoms, physical examination, x-rays, and labs. You cannot do one over the other. So the common doctor that you would see to diagnose SLE is a rheumatologist, but you can see any physician to come up to that diagnosis. A minimum number of criteria need to be fulfilled before a diagnosis is made. And again, having one blood test does not confirm a SLE diagnosis. So we do a few blood tests other than your immune-related tests. We also do your blood counts, your kidney function, your liver function, and I'll come to that in a minute. We also check your urine, and of course, we need to do certain basic imaging studies. So SLE can be misdiagnosed if only a blood test is used for diagnosis. So imagine getting this diagnosis with just a simple blood test and you start worrying about it. And I always tell my patients this. A lot of things in immunology is triggered by stress. So do not do the above blood tests unless you have symptoms. So what are the symptoms? Generally, SLE patients go through a period of what we call flare when they start showing symptoms. And this can happen every so often, sometimes even years apart. And then they go away for months, and this is called remission. So that remission can happen with medication and at times, in very rare instances, without medication. However, some SLE patients may have flares more frequently throughout their life. And these are the patients that we need to induce remission with our medications as fast as possible. So most of the symptoms in SLE can actually be grouped according to your organs involved. However, generally, the common symptoms that patients come to complain about are tiredness, aches, pains, feeling lethargic, feverish, a general feeling of discomfort, waking up in the morning feeling tired, hair loss. It's a very subtle symptom. I think always go through hair loss at some point in their life, and they feel, oh, it's normal. But I always remember this, what I was taught before. It's like when you wake up and you notice your pillow is filled with hair. That's not normal. Unexplained weight loss. For some reason, you're feeling feverish, you don't have appetite, and you're losing weight dramatically. Ulcers in your mouth, one ulcer, two ulcers are common, but these ulcers are, multiple and recurrent. Swollen lymph nodes in your neck or anywhere in your body. So these are the common symptoms I spoke to you about. Okay, just put in a picture form. So let's go through the organ-specific symptoms. So the common ones that we know of are your butterfly rash. This is what the wolf rash sounded, what we were talking about with the wolf rash. So basically it's over your cheek and it kind of spares your nasal labial fold, that is the fold around your nose. It's a photosensitive rash, and usually this happens because of this inflammation over your blood vessels, and that's called vasculitic rash. Recall I showed you a picture earlier. And you've got this very non-specific and non-malignant rash called the Raynaud's phenomena. It's not really a rash, but it's when there's constriction and spasm of your blood vessels in your fingers and toes, and your toes can change color from white, blue to red. Okay, so the other organs that we're talking about are your brain, and this can range from very mild headaches, feeling tiredness, weakness to numbness, tingling, seizures, and even memory issues. GI issues, which is abdominal pain, nausea, vomiting, heart valve issues, inflammation of the heart, lungs. So patients tend to complain about feeling shortness of breath, getting tired as they walk far, inflammation of the lining of the lungs. They have this cough which doesn't seem to go away. It's a very dry cough. And also the swelling of the legs, and that's when you know there's a possibility of kidney involvement actually. So what we notice when we do your blood, and why I told you blood counts are important, because in one of the symptoms of SLE, one of the signs of SLE we notice is low blood counts in terms of your hemoglobin, white cells, and platelets. Okay, let's go to treatment. Again, I tell my patients this, there is no definitive cure. We do not have a cure for SLE. However, the goal is to control your symptoms and signs. Why? We want to preserve your organs. We do not want issues of end organ failure. So the two common organs which what we call severe involvement of SLE would be your brain and kidneys actually. So each patient will be evaluated according to how severe the symptoms are, and this is what we call activity. So patients will probably ask me, doctor, is my SLE grade 1, 2, 3, 4? No, I say there's no grading to SLE. However, we can tell you in terms of, is this a mild involvement, moderate, or is this a severe? So like I said earlier, the severe involvement is when you involve the brain and kidney. And again, it has a range and grading of involvement there too. So the general treatment that every SLE patient is advised upon is sun protection. You do need to use sun protection of SPF 50 and above, any sun exposed areas. A proper nutrition and diet is very important, and this goes without saying with any diagnosis in immune related issues or none. Exercise, smoking cessation, appropriate immunization, and management of comorbid conditions. So it doesn't mean if you have SLE, you're not going to get diabetes, high blood pressure. It's possible. So please, a full approach of managing all issues is important. So in the past, everyone knows that any immune-related problem needs steroids, and this is what we call corticosteroids. And in the past, it's been corticosteroids alone, but we have passed that decades over. Currently, the mainstay and most important medication in any SLE patient is Plaquenil, or also called hydroxychloroquine. You may recall hearing this drug during the early days of COVID, where it was shown to be effective. However, we know today it is not. So every patient with SLE needs this medication, and it's got a few benefits in terms of preventing flares, your ups in your SLE, preventing skin issues, reducing your risk of getting kidney involvement, reducing your risk of getting blood clots. So like I said, every SLE patient needs this medication, and I'll always tell my patient, every other medications may be short-term, but this is for life. So one of the side effects of Plaquenil usage long-term is that it can cause deposits in your cornea. Hence, every patient needs to be seen by an eye doctor at baseline and again yearly. So let's go back. Remember, if you recall, I said steroids are the mainstay of treatment. Yes, it still is, in conjunction with other medication. Okay, steroids has got many side effects. It's got a few issues in morbidity and mortality due to its immunosuppressive effect. Steroids do decrease the swelling and pain-associated inflammation. Hence, it's very important in a lupus flare. However, we will only use the lowest needed dose for the shortest period of time. So steroid dose can go from low dose to moderate dose to high dose. But these days, we try not to use high-dose steroids long-term for the simple reason it causes many side effects. Hence, there is need for us to add other immunosuppressive therapy. So these are only needed for severe SLE patients, i.e. when there is actual organ involvement. So let's say you've got organ involvement of your kidney and or even your lungs or your brain. A second medication, which is an immunosuppressive therapy, will really help get you into remission fast and hence reduce the number of flares. So examples of these medications are azathioprine, cyclophosphamide, and really the list is exhaustive. Okay, so I won't go through them today. Okay, in any SLE patient, other treatment adjuncts are also important. Remember I told you about the sun protection. So don't forget, steroids also causes issues with the thinning of the bone, or what we call osteoporosis. So it's important every patient is supplemented with calcium, and the dose of calcium recommended is between 500 to 1,000 milligrams. Always tell my patient, Asian diet already has about 500 milligrams of calcium, especially if you drink milk. So top it up with another 500 milligrams of calcium. On top of that, you do need vitamin D. We live in a very vitamin D rich country, but most of us do not spend our time outdoors. So vitamin D recommended dose is about 800 to 1,000 IU. Regular exercise is important. Now, there are many issues associated with SLE and fertility. One, the medication itself can cause fertility issues. And of course, long-term active disease can also affect fertility. Patients tend to ask me, doctor, is having SLE meaning I'm not going to be able to bear a child? No, it's not true. SLE per se does not affect fertility if it is controlled. In fact, it's the doctor that probably will tell you time when you can plan pregnancy. I'll come to that in a bit. Okay, HPV vaccination has been shown to have some beneficial effects. Contraception, if you're going to use it, it is with low estrogen doses, and I think any gynecology colleagues would be able to advise you. Pregnancy must be planned, like I said earlier. Okay, and the reason why pregnancy must be planned is because we want your disease to be in remission. And this remission time can be between 6 months to a year. So depending on which organs are involved, we will advise you wait and defer pregnancy first. And again, please defer pregnancy until your steroid doses are below 10 milligrams. Why? Because any steroid higher than 10 milligrams puts your baby at risk of having intrauterine growth retardation, small for size babies, and early delivery. Okay, and of course, high dose steroids being used in pregnancy can also give the mother blood pressure and diabetes. So there's a few things that need to be discussed when a patient plans pregnancy actually. Okay, so outcome for SLE patient. This has improved tremendously over years. I think you probably learn or you may have read about SLE in the 1950s, 60s, where patients died due to infection. Not anymore. Why? Because we do know today that steroids are, even though they're the mainstay, they're not the only treatment. There are other medication that needs to be given, and patients are counseled and encouraged and guided through their journey. So most SLE patients I've seen are usually mild, to be honest. But we've of course got that 40%, that 30% who do require medications for a long, long time. And nearly all will require hydroxychloroquine indefinitely. Like I said earlier, it's for life. So generally, SLE patients tend to be more, SLE itself tends to be more active during the first few years of diagnosis. And this tends to be between the ages of 30s to 50s. Eventually, you go into what we call long-term remission, and you probably only need the plaquenil for life actually then. Many women get pregnant and deliver a healthy baby, and that goes without saying. A lot of data are available. So I always tell my SLE patients, do not let this diagnosis defer you from having a child. Do not let it prevent you from planning a family. You're going to probably ask me, is it going to affect my baby? No, the risk is very, very low. But of course, the fact that the mother has SLE, the risk of passing on the antibodies to the child is higher, but it does not mean there is a 100% risk of the baby is going to be affected. Okay, so lupus is also a leading cause of cardiovascular, kidney, and stroke disease among women. So don't forget, some of the treatments, such as steroid, puts you at risk of higher heart disease. So our patients are always monitored 6 months to a yearly for diabetes and high blood pressure. Okay, this is my last slide. Basically, what I want to advocate is please join, if you're an SLE sufferer, please join Persatuan SLE. This is an NGO, it is not for profit, and all information and even experience of other patients are always shared in here. They have regular activities, and I think it's something worth for every Malaysian patient actually. Thank you very much.
Okay.
Okay.
Thank you, Dr. Shamala.
Thank you.
It was amazing. I had a few questions,
Okay.
which has been answered by the slides.
Good. We can end now.
No, haven't yet. Let's see, I get some questions coming up. Thank you for all the questions. You all can still add questions. Let me guess. Let me see. Okay, there's one question from Miss Rachel Louis. Is SLE an inherited disease?
No, it's not. Like I said earlier, first of all, to be honest with you, we don't know what causes SLE, correct?
Okay, yes.
So it's multifactorial, and that's the right word to use. One, because why? There is a genetic interplay, but there's something in the hormones that triggers this. So is it inherited? No. You may have the antibody, but it does not mean you're going to have SLE. So no, it's not inherited.
Oh, which means if, let's say, your sibling has it, correct, it's not sure you will have it.
But you do have a higher risk of getting SLE compared to somebody else who does not have the antibodies.
Okay,
yes.
Understand. Let's go to the next question. Okay, it's from Mr. S.P. Chan. Is allergy related to SLE, or will allergy lead to SLE?
No, totally unrelated. I know it's an immune-related problem, but no, it's got nothing to do with allergies.
Allergy.
Yeah.
But the rashes, it is not caused by allergy.
No, it's not an allergic rash. It's actually inflammation of the tissues in your blood vessel, and that's what manifests as an rash. Actually.
Okay, that answered the question. So, let's see if there's any other question coming up. Okay, what is the risk of SLE to pregnant women?
Okay, there's no risk of SLE to pregnant women, but if you do have SLE and you're planning pregnancy, there's a few things that we need to discuss. Like I said earlier, I think pregnant in any ladies, pregnancy is it's a big part of a change in your hormonal changes in your body actually.
Yes.
So SLE, we know it's something related to hormones also. So very commonly, SLE gets triggered, or what we call a flare during pregnancy. But we know today that this tends to happen only if you have not been controlled. So let's say you've just been diagnosed with SLE and you decide, I'm going to, get married and plan a pregnancy. I'll always tell you, wait, let me get your disease into what we call remission. And when we say remission, we're talking about at least 6 months to a year and steroid dose of less than 10 milligram. So that is what we call a safe period to actually plan a pregnancy. So I'm sure you're going to ask me another question. Does SLE affect fertility? No, it doesn't. Okay, but the reason we tell you to defer is because we want to make sure you do not have a flare in pregnancy. And many studies have shown that if you do not get your SLE in remission, your flare can be quite severe. Why run into all that complications, right?
I believe it's because at that age where I remember the slide 19 to 44. So that is the age where people get pregnant and the hormone levels. Yeah. So
I think rheumatology is very depressing for the sense that all our patients are this childbearing age.
Yes.
So, a lot of our consultations will last for 30 to 40 minutes. Why? Because we need to counsel them.
Yes.
So with every SLE patient that I see, if you're within the childbearing age and there's plans for marriage, I'll ask you. If there's after marriage, I'll ask you about plans for pregnancy. And I'll always warn you, when we give you certain medications, you cannot get pregnant. Please let me know. Please come back when you're pregnant, because we need to counsel you correctly. Yes. It's very important. I also always advise them, if you're going to see a doctor in one hospital, if possible, make your obstetric follow-up in the same hospital, so at least we can discuss and decide what's best for you.
Correct. Okay. So there's another question coming. Does SLE increase risk of miscarriage or premature childbirth?
Active SLE does. SLE itself does not increase the risk of miscarriage. So if you're active during pregnancy, yes, it will. How do you prevent yourself being active during pregnancy? Make sure your disease is in remission before you get pregnant.
Okay. So you still have to get back to doctor so that your disease is in remission.
Please discuss.
Yes. Okay. Why are autoimmune diseases more common in female than male?
Good question. Please find out the answer.
Thank you, Ms. Rachel.
We don't have an answer. A lot of autoimmune diseases are, 50 to 90% more common in ladies. So interplay of our hormones, I'm not sure. The weaker sex.
Hormone plays a part.
Yeah.
Okay. Does SLE could cause muscle weakness? If so, is strengthening exercise suitable to be done by SLE patient?
No, SLE hardly affects muscles, but we have a few diseases which what we call overlap with SLE. So you've got something called myositis, even something called scleroderma, which can overlap with SLE. That's a big topic altogether. Okay, we're not going to go through that. But in these patients, you can have what we call proximal muscle wasting and weakness. So yes, certain exercises are very important in that. SLE per se hardly gets muscle issues, but don't forget, if you're unwell and your disease is very active, of course there is some muscle atrophy and muscle loss. So any strengthening exercises, even cardiovascular, will help.
Yes. Okay. Question from Ms. Rachel. Would you consider or have experience with duloxetine for fibromyalgia in SLE patients or for depression, anxiety in SLE patients?
Thanks, Ms. Rachel. That's a very big topic, to be honest. So I agree. Let's go through, okay? SLE itself, if I told you you had SLE, what's the first thing that's going to hit you? Medications for life.
Yes.
Correct?
That itself will cause me to have the anxiety and all. Yes, that's true.
So that itself is a very depressive and anxiety. I mean, you definitely be anxious about it.
Yes.
So yes, many of our patients become depressed, but I think counseling is very important.
Yes.
You need to tell them that you're there to help them through that journey,
Mhm.
get you into remission, and you'll be fine. Okay, so fibromyalgia can happen in 20 to 30% of SLE patients. Yes.
Mhm.
In fact, fibromyalgia are more common in my rheumatology patients, and sometimes it's difficult to diagnose. Why? Because again, it's according to a few criteria, and one of it is also just pain. And patients start realizing, oh, wait a minute, is it because I'm depressed? No, it's because you've got this disease that you probably cannot explain, you cannot understand, and you don't know why it's happening. So there's a lot of things running through your head, and that itself can cause you.
Yes,
to be
that's
so sometimes it's very
depressing.
difficult to decide: is it depression, anxiety, or is it fibromyalgia? Actually, okay. So duloxetine plus a medication called pregabalin are the only two medicines which have FDA approved for treatment of fibromyalgia. Okay, but I will never discredit the other what you call nerve painkillers that I think to use sometimes. These medications are available, expensive. Do I have experience? I tend to use more of the pregabalin. If they I tend to go to duloxetine. Duloxetine tends to help a bit more with depression also. Actually. So yes, it is a treatment.
Gardening is also a nerve and also it helps to relax. I think it's also
Yes, it
so,
does.
yeah, so,
Correct.
okay.
I try not to use, and if I do, it's for patients who are in vision. Because those who get a disease feel unwell, feel feverish, unable to sleep. It's not like say fibromyalgia actually. So once a patient's admission and they're still not right and not well, then yes, agree. You do need to probably change your diagnosis. It's not change the diagnosis, it's add on another diagnosis and treat that accordingly.
Okay. Okay. I hope that answered the question. Another question from Ms. Rachel Lee. And are there any reported effects in these patients in regard to fatigue?
Yes, it does. It does help actually. Don't forget, a lot of things in rheumatology helps with sleep. A lot, especially fibromyalgia. Sleep and exercise plays a big part. You feel better, you probably reduce your pain sensation a better. Because don't forget, what causes fibromyalgia is a heightened pain sensation.
Yes.
So you feel better after your sleep and exercise. Eventually, you get off your medications actually. So yes, they do help you because always tell my patients, take this as a short-term sleeping tablet. Okay, you start changing your lifestyle, get your exercise and your sleep better, you'll probably be able to off medications. Not SLE medications, the fibromyalgia medication.
But actually, in general, when we exercise, like normal people, we do feel better.
It's the endorphins.
Yes,
Exercise, everybody.
yes.
It makes you
So
feel
let's
good.
say that feels high. Okay. This is from Shantini. Does SLE influence the lifespan of the patient?
Difficult question to answer. Lots and lots of studies in this. If I tell you yes, you're going to be freaked out.
Yes.
If I tell you no, you probably think I'm lying. So I'm going
Yes.
to go in the middle ground. So, 10, 20 decades ago, that answer will be yes. It will be a straightforward yes. Okay. Today, no. But don't forget, we have got people who are resistant to medication, people who are not keen to start treatment long term, people who do not like to take steroids and tend to play around with their steroid doses. So if somebody goes into remission and stays well, it does not affect your lifespan. If you do not take your steroids correctly, or if you do take your steroids and overdose and don't come for your follow-up and we don't reduce your steroid, remember I said the minimum amount for the shortest period of time. So if you do not reduce your steroids fast, it causes higher risk of infections. So that can be quite bad.
Okay.
Yeah. So if you say, does it reduce your lifespan? Yes, if your disease is uncontrollable due to many reasons.
This means you have to do your regular follow-ups with the doctor.
I know it sounds terrible, but yes, I always tell my rheumatology patients, we will never discharge you from clinic. We just prolong your appointments when you're better.
But actually, it actually it involves emotion, so that makes it more,
Correct.
yeah.
Correct.
So
And
you
these-
need a support system.
Correct. And these are ladies who are planning to get married,
Yes.
planning to start a family.
Mhm.
There's the extended family to worry about.
Yes.
A lot of things.
Questions coming up.
A lot.
Okay. Does continuous exposure to the sun cause SLE to be serious?
Continuous exposure does not make it serious, but it can trigger your disease. Okay, so yes, it can trigger a photosensitive rash. It can also trigger other organ involvement to become more active.
Mhm.
So that's why every SLE patient has to use sun protection,
Yes.
and we advocate SPF 50 and above. Okay,
Mhm.
so even sitting in a fluorescent room with a fluorescent light, that even that has ultraviolet B rays in there. So I always tell my patients, you do have to put on your UV protection.
Even though you're not going under the sun.
Correct.
Yes.
Yes. So for children, I mean school-going children, I do give out letters to say, please stay away from continuous outdoor activity. Short forms of half an hour, 1 hour, no issues. But continuous exposure is not good. Okay, sadly.
Yes.
Okay. Number two, if you notice, it's one of the reasons why JPA will give you a letter to allow tinting. This was before tinting was allowed. Yeah. So it was one of the reasons patients were given allowance to tint their cars actually. Yeah.
Okay. So, okay. Thank you very much for all your questions. I believe if there's any other questions that you would like to ask Dr. Shamala, you can always post in the comment section and she will get back to you. Thank you so much for staying with us throughout our live chat today. And as she said, a few factors that you have to consider in SLE. Most important is get to a doctor and do your follow-up. And thank you very much. Thank you, Dr. Shamala. It
Thank
was
you for
so
having me.
informative and
Hopefully
yeah, I
somebody learned
enjoyed
something.
myself. Hope you all have a good day and have a nice day.
Thank you. Bye.
Bye.